further ado, I need to introduce you to our esteemed guest. Everybody should know, if you haven't met him personally, heard his name. This is Dr. Sato from Thomas Jefferson University.
Okay, go on. I have 2 mics. Okay, good. Good morning. So first of all, I'm losing my voice. We come from Philadelphia. It's very cold over there. I'm very happy to be here, but if you do not understand, I try to speak slowly, but please raise your hand. And then also, Melody gave me a lot of tasks today. So I'm not sure I can achieve any of these, but I'll do my best. And I'm very happy to be here and honored to be here. Okay. So first session, I'm going to talk about cluster issue this afternoon. So some of them may be cluster issues, so I just stop it. But I'll just review the most recent, up-to-date information on eye melanoma, uvea melanoma. So could you, yeah. And I am now a PI for the Immunocore dose expansion study, GP 100, 102. And I think Immunocore was coming to here to talk, but I might cover some immunotherapy issue this afternoon. Then also, I am going to discuss unapproved medication because nothing approved for eye melanoma as of today. Okay, next one. So probably this slide is not needed because most of you know the Philadelphia. So we are in Pennsylvania, Philadelphia, and then Sidney Kimmel, Mr. Kimmel gave us $100 million and then changed the name of school. So, so any of you interested in donating Jefferson, maybe you can change the name, like some, Mr. A melanoma program, anyway. So Sidney Kimmel Medical College of Thomas Jefferson University. It's our location. Next, please. So what I want to tell you is probably most of you know we have a very good team at Jefferson. And not only the eye melanoma team, Dr. Shield, Dr. Jerry Shield, Armand, and Sarah, and this very, I would say, excellent team who take care of the primary uvea melanoma. And my team is here. I have Dr. Olof join me, and I have the interventional radiologist, Dr. Asherman, Dr. Gonzalez, and Dunay, Zelinsky, and somewhere here. Sorry. So very strong team to take care of the metastatic uvea melanoma. And Dr. Aplin is a signal transduction specialist. Work with me very closely, and we have a very good, strong team to investigate inside of cells. Then myself, a tumor immunologist, and then we are developing a couple of new immunotherapy. Next one, please. Just gonna go over very basic. I'm not an eye doctor, but uvea is just surface lining of the eye, inside of the eye, consists of 3 parts: iris, ciliary body, choroidal. Any portion of this lining of the eye has melanocyte, which become melanoma. Next one. So commonly seen mass is nevus. Nevus is not rare. Maybe 5% of the Caucasian has nevus. Sorry. But roughly 1 in 8,000, very small chance of getting malignant. Tumor is larger, patients start having symptoms, and because of fluid accumulation, and then took the attention from the doctor. Next one. Melody? Yeah. Okay. Sorry. Yeah. Sorry. Yeah. Thank you. Yeah. So then, what kind of symptom? You already know. You don't need this lecture, but usually eye examination, and then blurry vision, floaters, flashes, some visual field defect. We have 2 eyes, so most of the time compensate well. So you might not know until doctors say, "Oh, you have some problem." But anyway, sometimes pain, but it's very rare. Next one. So uvea melanoma is very rare cancer. However, most common primary eye tumor in the adults in the United States, and roughly 5 to 7 per million in the United States. 2,000 patients. With eye, maybe seeing a quarter of them, and then we are seeing maybe tenths of the all new patient, and then Caucasian dominant, and very small portion, 4% of the cutaneous melanoma number. And age peak is at 60s. And survival rate is not so bad. The primary eye tumor, which is detected early, 50, 70% patients are cured. So it's not so, more pessimistic, but once metastasis develop, it's still very challenging. Thank you. Yeah, thank you. Oh, I have plenty of water.
Just in case.
Next slide, please. So I think I can skip this slide, but the majority of patients getting a radioactive plaque. And then Dr. Shiu's group starting external beam, radiation focused beam. Boston people are doing a proton beam. And in 25 years, more than 20 years ago, more than 50% patients are getting eye removed. But now they're only 10%, 15%. So as Aurora talked, they developed a new technology to minimize damage to the eyesight, vision. So eventually, this plaque radiotherapy may be replaced, especially for that small tumor, to be the new approach like photodynamic therapy. Next, please. So why you are here? Because some tumor escape out the cancer eye and then spread the metastasis outside. Eye treatment is excellent, 95% or above. Tumor is not going to come back. So treatment in the eye is excellent. Main focus is how to preserve the eyesight as long as possible. How to keep the quality of life of a patient, because patient lose their eyesight and then it's going to be very difficult to continue the same work. Anyway, roughly using 5 years, if you make ask a computer to make a survival curve, it's kind of smooth. So somebody say, and then it's getting increasing number, and you're going to be die after 10 years. But reality is, this actually, if you plot the actual patient, the 5 years is a kind of critical point. Roughly 2,000 patients develop some problem within 5 years. And then 5 to 10 years is second, dominant portion. But after 10 years, very small number. It's not going to be a zero. I usually tell the patient the Guinness Book record is 42 years. So it's not going to be 0%. And confusion is some paper, show the accumulation. 60% 5 years and additional 15% 5 to 10 years, or 75%. So number is kind of increasing. So that is not the reality. Reality is if time passes, your risk is going to decrease. Okay. And about the 5 years is generally speaking important. So therefore, we will do more testing for the first 5 years. Okay. And then nowadays, monosomy 3, class 1, class 2 tend to develop metastasis early. So we decide to just go the more frequent surveillance for the first couple of years. The idea is we want to fight. So if you don't want to fight, you don't need to know. So that's the kind of decision that you have to make. And then most of people here want to fight if something happens. So therefore, if you want to fight, we want to find out in early stage to allow you to have more treatment. Next one. So this is kind of summary of the all kind of a medical, some of you are confused, but traditionally, large tumor is not good. Ciliary body involvement, ciliary body anterior segment of the eye is not good. If tumor is spread out outside, it's not good. And local recurrence, it's not good. Some reason it's not fair, but the male is not good as female. And then a patient who are a little bit older, and the older age definition is very, disturbing, but usually 60 years or 65, I'm still thinking I'm young, but, Anyway. So nowadays, molecular testing is dominant. Also another confusion. And monosomy 3 HQ amplification, these are DNA analysis from the tumor. And monosomy 3 itself maybe increase the risk to maybe 1 in 3 range. 1 out of 3 patients develop metastasis if a tumor has monosomy 3. And additional HQ increase the risk to 50%. Nowadays, Castle class 2 is RNA analysis. RNA is a message from the DNA. So they categorize the class 1, class 2. If class 2, 50% to 70% patient develop metastasis in 5 to 10 years. So in these are kind of general scheme of the molecular testing, and then gene mutation, BAPA mutation is not good because BAPA is located in chromosome 3. So one of the chromosome 3 is missing, and the other chromosome 3 has some mutation. But one location, tumor tend to spread out. And then this rare mutation, FS31B mutation, somebody may have this kind of information. This is not so bad as BAP1, but tend to develop metastasis really late. So therefore, we just watch it a little bit longer. But overall, this disomy 3 patient, SF31B mutation is most detected. We have to be careful, but not like BAP1. And then PRAME. PRAME is a protein which it's interesting. This is like a rejection antigen. But if this is expressed, patients tend to have a little bit more aggressive tumor. In other words, even though class 1 PRAME positive has a little bit prognosis, like in 1 in 3 kind of range. And nowadays, there's a couple of companies start targeting this molecule also. Okay. On the other hand, now I'm kind of telling you the general thing. So if something happens in a good prognosis patient, and then you cannot blame me. Okay, it's just if something happens, 100%. Okay, and then now we have to work on that. Why? But I'm telling you just general information. Small tumor doesn't matter, even though monosomy 3 or BAPA mutated, small tumor has good prognosis. And then female, younger patient, some reason better. And disomy C, disomy 8, usually this is going to be get into the 10% or less range. And Castle class 1A, almost 100%. They try to make it 100%, so they keep changing some definition. But then one thing, this is EIFAX1 mutation. Mutation in general is bad, but this mutation usually prohibitory for the metastasis. So therefore, if your tumor has EIFAX1, it's all kind of many long name. Usually, patient does not develop metastasis. So of course, there's an exception, and then PRAME negative. So it's kind of general categorization of the tumor. So I think somebody already explained that, but I'm just going to rephrase that. Next one. Is Melody back? Can I keep talking to until noon? I'm kidding. Yeah. No, I think there's some next session. So this is also a mystery. And why this happened, I don't know, and we are working on that. But if something happened, that usually happens in the liver. This is like 80% of case in our series, very long time ago before we start intervention. So liver is dominant, next is lung, next is bone, skin, lymph node, but surprisingly, brain tumor is very small in number. Skin melanoma, 30% patient who has stage 4 disease has brain mets. We only see on less than 5, especially it's a very late stage we see the brain mets. So therefore, strategy is how to detect the liver tumor earlier, how to attack on this. That's a current strategy to improve the survival. Next one. So this is one example, a very small tumor, even a seed. It's kind of, we like MRI, no radiation, much more sensitive. But sometimes insurance company deny it, so ultrasound is probably second best. CT scan is not so useful, and then NCCN guideline did not mention that CT scan is good for the screening for the eye melanoma, either MRI or ultrasound. So, yeah, then this person will just wait. April, this size, June, replace the liver. So sometimes liver tumor grow like this way very rapidly. So therefore, if you want to fight, early detection is in general is recommended. Next one. So this is a mystery, why eye tumor travels to the liver, and there's many theory, like a growth factor, insulin like a growth factor 1 receptor is expressed in tumor. Liver has IGF-1, and liver has a HGF, hepatocyte growth factor. So tumor like these kind of microenvironment. And then there's some chemokine receptor. Chemokine is an attractant of the cells. Receptor is produced, liver produce chemo attractant. So that is kind of a reason, but nowadays one of the hypotheses is like some type of hypoxic immunosuppressed microenvironment allow the tumor to grow in the liver, because there is a new category of the eye melanoma, so-called TCGA data analysis class group 4. They are living in a very hypoxic immunosuppressive environment. The tumor escaped out to have one new location, and liver is kind of similar to that, because liver artery and the vein is mixed up in the sinusoid. In other words, liver oxygen level in the cells level is kind of not same as lung or heart. So this kind of a hypothesis that researchers are working right now. So eventually, we may find better thing. But prevention is difficult, because when you have an eye diagnosis treatment and tumor is already out. So that's our oral treatment, it may not help, because if tumor is treated, detection early, is important. Taking care of the tumor early in the eye important. But majority of case who develop metastasis, the tumor in the eye is already dead. So why tumor is spread out? Because tumor cells out before that. So therefore, any kind of interventional approach, blocking a c-Met or some kind of chemokine is not going to be effective, because it's already here. So that's a strategy that we are making right now. Next one. So this is a reality of the currently available information. So maybe changed, but FDA approved medication, Yervoy, ipilimumab, PD-1 antibody, nivolumab, or Opdivo, and Keytruda. Response rate is miserable. So, and there's combination of Ipi/Nivo. So therefore, if we have no choice, we suggest Ipi/Nivo, ipilimumab, nivolumab, because response rate increased to 10%. So, but again, once you have a response, that is durable. So therefore, before giving up, at least we should try it. But this is a reality. Compared to a skin melanoma, it is very low response rate. Probably because tumor cell doesn't have a lot of immune recognition, or immune cell is paralyzed either way. So MEK inhibitor was a topic 5 years ago. Selmetrib, almost approved. Went to phase 3. I'm sorry, didn't work. Very upsetting, because we are one of the site. And of course, combination of MEK plus something is very interesting in a mouse system. It's kind of killing a tumor very well, but patient is suffering. So toxic. You can very difficult to combine with MEK inhibitor with others. So now we have to think of something different, but that's a kind of a signal inhibitor trial dilemma right now. So then majority of patient has liver metastasis, die from that. So therefore, our current target, even though this might not be curative, at least try to prolong the life as long as possible. Avoid the toxic pain in the liver failure. That's our current approach at Jefferson. Next one, please. So I show you a couple of times, and they may change a little bit. So early detection is important, because if patient is sick and we can't do many things, we have to talk about hospice care, but the patient doesn't want to do that, so it's kind of challenging. But if a very small tumor and then more than 5 years, we have a very good response or prolongation of life by just cutting out or radio frequency ablation. We call our microwave cooking. So, our doctors, interventional radiologists doing that only if time to systemic recurrence is relatively long and then solitary, single lesion. So, and then, but most of people have multiple liver tumors, so killing one tumor doesn't make any sense. Sorry. So therefore, a whole liver treatment is needed. And then liver is not dominant site. We use a clinical trial. It's important also. Now, if they don't have the liver-directed treatment, most of patients come to systemic clinical trial. That is going to be a discussion after this. So, but we think liver-directed treatment as of today is the most efficacious treatment. I'm going to show you evidence. So there are a couple of approaches: hepatic perfusion, this is PHP, including that, and chemoembolization, immunoembolization, radiosphere, drug editing beads. Depending on size, location, number, we have a melanoma conference every week. Decide which is the best option. Again, clinical trial, now it's a couple interesting clinical trial. Especially, I have to be careful in talking about immunocore because I'm a PI for the site, but immunocore medicine is very good, I would say. Then, if it is very small number, keep radiating tumor, cryoablation, microwave. This is a kind of general schema. I want to show you why. Next one. So this is a Jefferson trial, and one is probably I can skip it because there's a clinical trial session after this. We are doing an adjuvant trial. We have at least 5 different clinical trials, but we're going to discuss this later. Skip it. This is Sutent. Sutent, we tried that more than 10 years ago for the stage 4 patient who has metastasis. And Sutent is very weak medicine, we thought. First of all, toxic, and we have to cut the dose by 2,000 patients, in 2,000 patients. And then only 1 shrinkage out of 20. So, and then at the same time, we saw that 2,000 patients has no growth. For some of them, more than almost 2 years, nothing. So we saw that maybe this is kind of more stabilization effect. So, and then why? And there's 3 major factors. One is, tumor express c-MET, c-KIT. Medicine suppress that. That might be weak. Medicine has anti-angiogenesis effect. You suppress the new vessels. This is very, if a patient had a scar, injury, and then we have to stop the Sutent because never heal. So especially small new vessels, maybe Sutent work. And the other thing is Sutent is enhancing immune reaction by suppressing suppressor cells, double negative. So based on that, we saw that the stable disease may come from that. Why don't you use that for the very early stage, like a high risk? So, and the patient keep coming after class 2 diagnosis, monosomy 3 diagnosis. So we decided to choose this because we know this medicine. And then we cut the dose to half by, approved dose of 50 milligram, we are using 25 milligram. Then this always institutional historical control is joke, but Wilson has 1,000 patients, okay. So we just pick up the patient who match to the current patient who receive it. So this indicates that Sutent may not have a perfect effect, but somewhat suppressing the progression. So that's a source, a basis of this published in ophthalmology. This is a source, basis for the current clinical trial. And then we compare the valproic acid Sutent because valproic acid is HDAC inhibitor, class 2 to class 1 switch. So therefore we use that, and then Sutent is second arm. And now we are doing a Sutent for 1 year. So, but the problem is we have to wait 5 years, to see whether it's work or not. And then hopefully by that time we have new medicine. But now we are doing this. It sounds like we are reproducing similar result, but hopefully we can just present a couple of years from now. Next one. So this is the kind of one thing that I want to encourage you. Several weeks ago, there's a paper in the JAMA ophthalmology saying that treatment outcome hasn't changed for 20 years. This is Boston. So now we're going to send this to the same journal. So this is a patient who is many years ago, most patient is getting systemic chemotherapy like dacarbazine. So this is a new population patient, more than 80%, 90% patient get the liver-directed treatment, immunoembolization, I mentioned it. And then 636 cases, this is the largest series in the world. Then compared to the previous 20-some years ago data, this liver metastasis death has prolonged from 4.8 months to 16.4 months. Actually, by using a liver-directed treatment for the liver-dominant tumor, we are showing strong survival benefit. Okay, this is a kind of different result from many other institutions, but we are doing this. And then next, please. So in that case, okay, Dr. Sato is aggressive finding out the new tumor in the early stage, so therefore that automatically prolong life. So-called the lead time bias. So we did a multivariate analysis that we conclude that is not true. But this is from eye diagnosis treatment to death. So same population patients come to the Wilson Eye Hospital in Jefferson who has liver metastasis, 101 cases 20-some years ago compared to more than 600 cases. We are showing a survival benefit from the eye treatment to the death. So, and then again, there's many factors, so therefore we did a multivariative analysis to reduce the influence of other factors. Still, this is positive. That means we have some promising kind of result by using a liver-directed treatment. We are able to improve the survival of patient and then also the overall survival from eye treatment. So therefore, hopefully after this our paper is published, eye doctor may stop saying that you don't need to have any MRI. But we need some time. Next one, please. All right, this, we stop it here. And then there's many clinical trials. The standard statement is consider clinical trial. So, because that's the only way to improve outcome. And then, again, our institution still, we have to ask interventional radiologists to attack on the liver until systemic treatment produce better result. Better result mean at least 30% to 50% response rate. Current ipi/nivo is, as I say, 10%. So it's not comparable. So, but again, this is step by step, one by one, and each patient is different. So, and hopefully, we have no time. I have no time to talk to each of them. But if you have any question, just send us an email. All right. Thank you.